I'm delighted to be here, and I think, first of all, congratulations, Manos and Paul, et cetera. This has been, it's a very innovative meeting, and I like the new approaches to how we do this. So if you'll notice my talk, innovation in STEMI management, there's a question mark at the end. So we'll start with that and see where to do. So I don't have any specific disclosures. I think this is a really challenging talk to cover in 10 minutes. But I'm going to hopefully to make some take-home points of where we are. So really, this is the problem, plaque rupture. The solution is really 1-hour artery cleaners. And we have made remarkable, I've been working in STEMI for more than 30 years. And really, I'd start off by saying it's remarkable the progress we've made. And I would tell you that's one of the challenges as we're going to come back to. So what's standard of practice now? PCI centers should do PCI in a timely manner, less than 90 minutes. Short distance transfers should have PCI in a timely manner, less than 120 minutes. And it's still a little controversial for long distance transfers or those with an expected delay. We're not really going to cover it now, but this is still a big issue all around the world. So my one most important point I'll start off with innovations with STEMI is that all of you out there, you should be doing outstanding STEMI. And in your own institution, if you're not, the first innovation is make sure your institution is doing what you should do and what's capable and what's possible in 2018. So that's number one. You have to do that yourself. I would start off by also telling you that this is personal for me. You know, on the left side is my grandfather who died when I was a sophomore in high school from acute myocardial infarction. And if it was today, there's no way he would die. And on the right side is where I think we need to go is my father who just died 2 years ago of out-of-hospital cardiac arrest and didn't need to if we actually are doing the things that we want to do. The second thing I'll do is a patient of mine that I took care of for a long time. And at his funeral, they said, you know, Pastor was always wonderful. We told him, I love the way you look outside the box. And he said, I didn't even know there was a box. And I think that's the way we need to approach our care when we do this. So when you look at STEMI research and you look at translational research, reperfusion injury trials, hypothermia trials, post-conditioning, hyperoxemic oxygen, stem cell therapy, etc., there's a million of them. There's always strong preclinical data, and there's always good open label phase 1 trials. But then what happens? Here comes circumstances beyond our control, and I'm going to show you a couple of them, right? The field is littered with unsuccessful phase 2 and 3 trials. And here's it, cool AMI, acute MI, less than 6 hours, randomized primary PCI with primary PCI plus cooling, looking at infarct size, no differences in infarct size. Infarct size is about 14%, we'll come back to that. But when you looked inside the numbers, maybe the patients that got cooled faster in anterior infarcts, maybe you saw a difference. That was true both in cool MI and ICE-2. Post-conditioning, great preclinical data, great small little trials, but when you actually did a randomized trial, this was done in Minneapolis with Jay Travers, 100 patients randomized, only occluded arteries, randomized to post-conditioning or not. Important when you looked at the data, no mortality basically. One MACE and it was related to stroke, one acute stent thrombosis, one TVR, no recurrent MIs. These 100 patients had no events, all right? No difference in infarct size and no difference in myocardial salvage. So post-conditioning, and it didn't reduce the incidence of microvascular obstruction. But look at microvascular obstruction was in about 60% of the patients, and there was 0 events at 1 year effectively. So conclusions, post-conditioning did not decrease infarct size, very low event rates, and we are going to look at the 1-year data that will be coming up later this year. So what about cell therapy? So this is in 2006, this is a Repair MI trial. This is really one of the highlight trials of the year, was a Repair MI. And they showed that there was a difference. If your EF was less than 49%, you had a significant improvement in LVF by LV gram with bone marrow mononuclear cells, and in particular if you were treated late. More importantly, I think the Repair MI data at 5 years showed a decrease in event rates with the cell-treated patients. So this generated a lot of enthusiasm. Going forward, we know that bone marrow, as we get older, the number of our stem cells and the potency of the stem cells decline. So instead, it would be nice to give an allogeneic cell, so an off-the-shelf cell to patients with cell therapy. We did that, actually showed you might be able to improve ejection fraction in anterior infarcts. And you had the Caduceus trial, which really showed a 1 month post-MI, patients randomized to autologous cardiac-derived stem cells had a reduction in scar mass and an improvement in viable mass. So this laid the groundwork for the All-Star trial. And I think the All-Star trial is really illustrative of this problem with innovation in STEMI. So their first one, there was a phase 1 open label trial, and then there was a phase 2 trial that was supposed to recruit 300 patients with large infarcts. So with 30 centers over 4 years, the actual recruitment was about 0.1 patient per month per site. Do these patients even exist anymore? Question number 1. So actually, when you looked at it, we actually ended up with about 140 patients in the trial. EFs were about 39%. Scar sizes were about 24%. So actually larger than the Coolett trials. And there's another trial in Europe that was just done that had scar sizes of 35%. Whether it's really scar size or not is a separate issue, but large infarcts, large scar size. Well, no differences in scar size when we randomized the trial, but it was woefully underpowered because it was half as big as it should be. And more importantly, no events. So these are the largest infarcts. Large anterior infarct, scar sizes over 20%, and 0 deaths at 1 year. All right, and very low other events. So conclusions, no difference in scar size. There was improvement in volumes in BNP, very low clinical events, favored sort of the treatment group. But there was challenges in recruitment, and then there's challenges in measurement. So we use MRI as sort of the gold standard, but I'm going to show you a slide that says, is MRI really a gold standard? Because you have both dropout and there's significant variability in MRI as an endpoint. So when you look at it, I would say starting off with STEMI, these are the challenges. We've done so well that we have a changing natural history. I have an editorial in Circ Research coming out now that says, have we reached futility in STEMI trials? Because we looked at 1,500 patients enrolled in trials with large infarcts, and the mortality at 1 year is 1%. And it's because we've done so well. Second of all, it's a dynamic process. So what happens on day 1 versus day 3 versus day 7 versus day 30 is very different. And then second of all, it's really hard to enroll high-risk trials. And personally, I think if we're going to go forward, the 2 groups to work on is those patients with an abnormal IMR, and we do that at the time of the STEMI. I think it's critically important. We should do it almost routinely. And then second is cardiogenic shock and out-of-hospital cardiac arrest, and I'll end with that in a few minutes. But another really big problem in this is we have suboptimal endpoints. There's no gold standard, and MRI is not. This is actually data from the TIME trial that we just published in Circ Research. So first of all, there was about a 25% dropout. And you look at the paired data on the left, you saw no differences in ejection fraction. Everybody was 50%. Everyone got better. But who dropped out? The patients who dropped out were on the right side, and those are patients who had the EFs of 35%. So all these trials that look at serial MRIs lose about 25% of the patients in the trial, and they lose all the sick people. So that's why you don't see any differences in the trials. So now I'm saying, there's a lot of STEMI work going on. These, I'm going to say, these are research refinements and are not going to make very much difference in our care. Optimal antiplatelet antithrombin, stent choice and design, radiofemoral, thrombectomy, post-conditioning, etc. Those are minor. Where can we make a difference in STEMI? And this is a list where we can make a difference. And this is, I love this quote by Bill Gates, and it's really perfect for Steve's talk. Humanity's greatest advances are not in the discoveries, but how those discoveries are applied. So I'll go back to the first point on innovation. Every person out here should make sure you are doing great STEMI care and that your outcomes are 1% mortality at 1 year. So number one, that's where you should be. That's the standard of care now. But these are the challenges. We have a lot of work to do with multi-vessel PCI. And I think the complete trial is going to be a really important trial pushing us forward. And likewise, in the culprit shock trial was the start of multi-vessel disease with cardiogenic shock. Number two, in-hospital STEMI. Almost nobody has protocols to take care of in-hospital STEMI. And the most dangerous place to have an MI right now is in the hospital. So this needs a lot of work for sure. Patients with expected delay, and I really think we've come to a pharmacoinvasive approach. I'm not going to cover it today, but it is worthy of research, but really mostly all around the world and not as much in the United States. So the two big ones are out-of-hospital cardiac arrest, both prevention, identification, and treatment, a huge area of research. Advanced cardiogenic shock, I think, is really important and a place where we can make a difference in the next 5 years in particular. And culprit shock was at least the first step because it was an excellent design. I think cell therapy has a role, but it'll be specific, really a specific group of people. And then finally, I'll end with quality and reporting. And I think this is really an opportunity for innovation. And a paper that actually we just published with Steve was value-based care. So what we did is we looked at our retrospective STEMIs, and we applied the Zwoli risk score. And it turns out half of your STEMIs are low risk. And if you look at those low risk, those patients don't need to go to the CCU, and they can go home in less than 48 hours. And so then we implemented that using electronic medical record, and we looked at it prospectively. And if you can see, the patients who followed the protocol in blue that were low risk and went home had very low event rates, basically no mortality in hospital and almost no mortality at 1 year. If you were low risk, but for some reason we thought you needed to go to the CCU or you're intermittent, and then the high-risk patients were where the events were. And when we looked at it, you could see more than half the patients went home in less than 48 hours as planned, and it saved the hospital system nearly $1 million a year. So I would call that a very important innovation in STEMI care that all of us can do in terms of doing value-based care. So with that, you have to be very careful if you don't know where you're going because you might not get there. There still are opportunities for innovation in STEMI care, but we have to be thoughtful about where those are. Thank you.
Great, Tim. I think, you touched on a number of things in STEMI care. I'm really glad it wasn't about rescuing side branches and things like that. It really is about what we can make a difference in. One of the vexing problems for me as an interventionalist in a public reporting state are these cardiac arrest patients. What do you think about that? Yeah, critically important. You saw it was on my list on the bottom with quality and public reporting. And there's some good data in it, but we need to look at it more carefully. But I think public reporting in the states that do it routinely has pushed STEMI care backwards. It's less likely to take care of high-risk patients, and the high-risk patients are really out-of-hospital cardiac arrest and cardiogenic shock. If you looked at we have a paper that we're looking at right now. Why do STEMI patients die? Do you know why? In 2018, the #1 cause of death is brain death. #1 is brain death. #2 is cardiogenic shock. But if you look at the patients that died of cardiogenic shock, those are people who died before they got to the cath lab. So really, once you get to the cath lab, the number of people that die is very small. And so those are the people that are the problem with public reporting. So we want to work on the people that are dying the most, and we have to solve the problem for sure, Duane. It's not simple.
Tim, with a 1% mortality rate at 1 year, what is the right outcome? Because clearly mortality no longer is.
Yeah. So that's why I think, for me, really, and now would it make a difference at 20 years? The answer is some of those patients with large infarcts will have a difference potentially in heart failure at 10 years or 20 years, but it's too expensive to follow that. So I would say in terms of trial design, if we can actually find a way to inexpensively follow people for longer periods of time, that would be a great innovation. But you're not going to make a difference in mortality. You're just not. And that was my problem when you're talking about the door-to unloading trial, is if you just take unselected STEMI patients, they all do fine. So that's my problem, because it might be a good thing to do, but you're testing it in the wrong patient population. So, and so I think, Steve, the quality things, like I think that if every place in the United States did the low risk, the value-based approach to care, look how much money we would save and how much care would be better. So those, I think, are opportunities for innovation.
I think the other thing to keep in mind is the other aspect of what's important to a patient. What's their symptom burden? What's their functional status? Have they returned to work? Yeah. And so if you have an innovation or opportunity where you reduce infarct size, and so the proposition is that they're going to have less heart failure, you're not going to necessarily see that in mortality. You've demonstrated that, but you might see that they are able to continue to mow the lawn and go golfing, whereas they weren't if they didn't have that intervention. So it's to capture the patient-reported health outcomes that matter to the patient.
Another opportunity is actually adherence. If you look at the people that, like the patients who take their dual antiplatelet and their statin, they have almost no events. The events are all in the patients that don't. So another area of innovation, I think, is finding a way to work on that patient population that for some reason is not compliant.
And just to be clear, that's not necessarily just because they aren't taking their medications. It's everything that goes along with being adherent. So
it is.
It's not just the effect size of the adherence, it's the healthy behavior effect that goes along with it.
Yes, completely agree.
Tim, you made some comments on how can we improve? So we have to be better as interventionists, and I think you indicated a little bit of access too. So when we do structural cases, we know more and more that we actually miss a lot of patients. We just don't see them. They're not referred. They're not treated adequately. They never see us, right? But in coronary disease or STEMIs, how do you know from any kind of data how many patients, because of lack of access, lack of education, are we missing? Is this an opportunity? Because we are so ineffective in the United States.
So,
right?
Go ahead.
I'll tell you, because this is one that's really annoyed me for a long time, is there's a paper by Dr. Kokanen that shows, around 2001 to 2006, this is where this was kind of recognized that there was a lack of access to STEMI care, primary PCI specifically. And so there was a 44% increase in the number of cath labs over the ensuing 5 years. And that led to a 0.9% increase in access from 80 to 80.9% of patients. So what does that tell you? That tells you as physicians, we decided to just build cath labs to compete with one another rather than to build cath labs to bring it to where they were needed. And that's going to be the same thing for structural heart. I mean, there are like 1 billion structural heart programs in Boston, but they're not actually in Western Massachusetts where the people are. Now, mercifully, this is a semi-elective procedure, so maybe there's a little buffer there of transferring patients in and centers of excellence, and that's kind of going to be actively debated. But when it comes to STEMI, we actually failed at that.
So let me add two things for that, because it's a really important question. First, in the United States, I think there's places where we have too much access. And I'll tell you an example now in Los Angeles, there's too many STEMI receiving centers. And in another talk I do, I actually show two patients, 50 years old, clear-cut ST elevation, went into labs, did not get their artery fixed for some reason or another and got transferred and died. Two 50-year-olds that died. But they're not even in any registry because they didn't get a PCI, okay? So that's one problem. I think too much access, and what we need to do, and I started off by saying the best innovation is each one of you need to make sure you're doing it great at your site. Second thing I'll say is around the world, STEMI in the United States is one thing, and that was my focus here. But STEMI in the world is increasing. So if you look in Malaysia and India and in Russia and China, the number of STEMIs is increasing dramatically. And the age at STEMI onset in Malaysia and India is now around 40. So this is still a worldwide problem, and access worldwide is a huge issue.